Great. Good morning, everyone. Everyone come on and take your seats. So thank you, everyone, for being here. Welcome to Integrative Medicine Grand Rounds. So I have the distinct pleasure this morning of introducing our speaker. I'd like to introduce Dr. Zev Schumann-Olivier. He's the Executive Director and the Research Director of the Cambridge Health Alliance Center for Mindfulness and Compassion, the Medical Director for Addiction Services, as well as the Director of Addiction Residency Education within the Department of Psychiatry at the Cambridge Health Alliance. He's also the Director of the Mindful Mental Health Service. So in addition to his appointment in psychiatry at the Harvard Medical School, Dr. Schumann-Olivier is also a faculty member in the Department of Biomedical Data Sciences at the Geisel School of Medicine at Dartmouth. He's a board-certified addiction psychiatrist and has been involved in research and clinical care of patients with addiction, mental illness, and chronic pain in both psychiatry as well as primary care. He's the founding member of the Mindfulness Research Collaborative and is also a part of the NIH Science of Behavior Change Initiative. He's a principal investigator of a multi-site trial of mindfulness in primary care office-based opioid treatment. And particularly relevant to today's topic, he's leading the MindfulPC project, which is an innovative initiative integrating mindfulness for behavioral health outcomes into the primary care patient-centered medical home. So I'm very delighted to have Zev speak with us this morning. Please join me in welcoming Dr. Zev Schumann-Olivier. Olivier.
So let's see, can you hear me on this microphone? That's always a problem with it being too loud. It's good enough? Okay, great. Well, it's really an honor to be back here presenting. I haven't actually walked the pike here in like 9 years since I was a fellow here, so it's really fun to be able to come back and present. So today I'm going to talk about our work around mindfulness and behavior change with this focus on chronic illness self-management in primary care. Let's see if this works. It doesn't work. Okay. We have had numerous sources of funding for the projects here. I just wanted to recognize the commitment of and contribution of the funders, including the Osher Center, which has funded one of our pilot projects. And I wanted to just disclose that I have no financial conflicts of interest, but I am the director of the Center for Mindfulness and Compassion, which is a division within the Cambridge Health Alliance, which is an academic public hospital. Our mission at CMC is to enhance the health and well-being by integrating in healthcare by integrating mindfulness and compassion into healthcare and our communities with a commitment to inclusivity, accessibility, and diversity. And so in that role, CMC does hold mindfulness training programs that are reimbursable by insurance. We also provide education and training that receive individual private tuition payments that support expenses and contribute to the mission and the vision of CMC. So I did want to mention that. So this is really the graph to help you understand what Cambridge Health Alliance is. So we are the primary public safety net hospital system for the Metro North Boston area, going from Cambridge all the way out to Revere. And we have 14 primary care health centers that are dotted across that region. And that's where we were working to think about how do we integrate mindfulness actually into healthcare. And the idea was to be able to leverage the primary care presence that we have across the region to be able to begin to integrate mindfulness into healthcare. And we really focused in on primary care because in many ways primary care is the heart of the healthcare system. And if we could bring mindfulness to the heart of the healthcare system, then that warmth and presence and compassionate impact of this intervention and this way of being could potentially kind of flow throughout the rest of the healthcare system by starting in primary care. And at that time we were going through this primary care transition to patient-centered medical homes. And so it really felt like we were going through a stress test as a healthcare institution, and mindfulness may be able to help us with that stress and keep the system from collapsing. At its heart, primary care also is the place where chronic illness is dealt with. And when you look at preventable mortality in this country, you really need to focus in on chronic illness and behavior change related to chronic illness. It is complex working in primary care and working with patient-centered medical homes around the primary care patient. We had to take into account various types of systems change, working with the primary care team, figuring out how to build referral processes into the electronic health record, finding stakeholders, key stakeholders within clinical staff and leadership to be able to support shifts within the primary care system to allow integration of mindfulness at every level. Facilities and supplies, where do you store 25 cushions and 25 mats in a primary care office that has no space? And how do you get staff to buy into doing that? And then what do you do when at the end of the day you have 12 patients that all come in at once to check in for a group when front desk staff is preparing to leave? And how do you have them buy in as well to the idea that this is actually good for their patients and good for their system? So when we're thinking about how to really integrate mindfulness into healthcare, we really have to be mindful and aware of all the different factors that go into this if we're going to be successful. And so we really set out on this process, and it took about a year to be able to fully get buy-in across the entire healthcare system. And you can see the center was initiated as a way of helping to really implement this project with support of the institution with various different patient-centered medical homes, hubs across the region, and the support of the departments. We did trainings at every single primary care site across our healthcare system on mindfulness with all the staff. It was not required, but it was strongly encouraged. People were allowed to opt out if they want to, which is always very important when introducing mindfulness into the workplace. We had staff retreats. We had mindful lunches. We had mindfulness at work. We did intensive training for both primary care providers as well as our behavioral health therapists who were interested in participating. And we ended up with training 14 behavioral healthcare providers and 2 primary care providers to be able to deliver the mindfulness-based intervention within primary care to patients. So we met with our CEO to try to kind of sell him on this idea, and it just so happened that, I don't know if you remember this Time magazine that came out about 5 years ago. It came out the day before our meeting with the CEO, so we got to throw that down on the table, and that really helped. It also had within me and many of our members of our team a strong reaction as well, that when you look at the face of the Caucasian woman on the front of Time magazine, and really think about what does it mean to integrate mindfulness into healthcare. Well, it means making mindfulness accessible, inclusive, and accessible to a diverse population that we serve within healthcare. And we really formed our center with a commitment to this accessibility, inclusion, and diversity. And I really believe if any integrative medicine approach is going to be integrated into healthcare, it needs to be one that can be inclusive and culturally adapted for various populations within our healthcare system. So this is just to show you the consort diagram. I love consort diagrams. If you're a researcher, you understand the importance of these. We had 344 patients in our first Mindful PC study that got referred through Epic referral. We narrowed it down and randomized 81 patients that wanted to go through the program. We randomized to 54 to this mindfulness training for primary care intervention, which I'll tell you about in a little bit, versus a low-dose comparator. And I'll explain a little more about what that was. Our primary outcome for this first study was looking at anxiety using the PROMIS anxiety scale. And then we had secondary outcomes looking at accessibility to our different racial and ethnic minorities, as well as looking at whether or not people could initiate an action plan if they around chronic illness self-management. We also were looking at outcomes like stress, depression, and self-efficacy. So in this comparative effectiveness RCT design, we had 8 weeks of a standard mindfulness training for primary care intervention versus a 60-minute introduction to mindfulness and community referral. The idea was, right now, the standard of care that seems to be emerging is that you might get some introduction within your healthcare system to just some brief mindfulness, and then get referred to an app or to the books or to an external program that might be a private pay program. And we wanted to see, does actually integrating this into primary care, making it insurance reimbursable and available, will that increase accessibility? Will that increase people's capacity to make behavior change? So the Mindfulness Training for Primary Care program is insurance reimbursed. In this first study, we actually billed everything as group psychotherapy. We now are able to bill our groups as both group psychotherapy and as group medical visits, depending on who's leading. So they're currently delivered by both mental health clinicians or by primary care providers in primary care. And the MTPC groups are 2 hours long. They last 8 weeks, and we do have a 7-hour day of silent practice that we offer. And in this case, in this first phase, we actually had people meet with their PCP between week 6 and 7 to come up with a collaborative action plan. And that was really about this idea of creating a collaborative chronic illness self-management action plan. So just to show you our data on inclusion and accessibility from our phase 1 study, we actually found that 52% of people who ended up enrolling in the program had government subsidized health insurance. And so that was, our goal was to reach at least 50% of people on government subsidized health insurance. We also have, we have 33% minority population at CHA, and so we actually had 36% of people who were a cultural, racial, or linguistic minority enroll in the program. And we met our goal there, which I was excited about, making mindfulness accessible for our community. And just a few, I don't know, does this work? Yeah. So our primary outcome was looking at anxiety, and we did have mixed effects analysis between group analysis, find a significant effect on reductions in anxiety, as well as reductions in mindfulness and self-compassion. Increases in mindfulness and self-compassion in the 8-week program compared to just the 1 hour and referral to community resources. It's notable that within group analysis, pretty much everything did change within the mindfulness training for primary care group. But importantly, even just with 1 hour of mindfulness, the perceived stress did seem to be reduced at 8 weeks in the low-dose comparator, which has us kind of interested in this idea of low-dose mindfulness being particularly helpful with stress, even if it may not have a significant impact on anxiety and depression symptoms. So around this time, we were also building this mindfulness research collaborative, which is a group of somewhere around 10 to 12 different principal investigators, which started here in Boston, really committed to trying to understand the mechanisms of how mindfulness meditation works. And so this meeting actually took place at the Brigham. And out of our meetings, early on, we came up with this review framework, which was published by Britta Holtzel back about 10 years ago now, about how does mindfulness work. And what we had found in the literature was basically these 4 mechanisms. One was through impacts on attention regulation and cognitive control. The second was around body awareness. Third was emotion regulation, both reappraisal as well as exposure and response prevention, and reconsolidation. And then we found changes in perspective on self. And this has been a model that has been adapted and worked from over the last 10 years, but basically falling into roughly these categories. And from that, I say another model that kind of emerged from David Vago, who used to be here at the Brigham, was this SART framework that also had similar ways that mindfulness meditation might be working through self-awareness, through self-regulation, and through self-transcendence with these similar neurocognitive mechanisms listed on the right. So out of that came this initiative to apply for the NIH Science of Behavior Change Award, where we really tried to start to target self-regulation and its impact on behavior, which I'll talk about in a minute. But what we started to do in our program was really make sure that our mindfulness-based curriculum in primary care was targeting self-regulation and trying to augment it using this mechanistic approach, and trying to really make sure that it impacts chronic illness self-management and health behavior change. So what MTPC did was integrate you may have seen the paper, The Warp and the Weft, by Crane, which is really talking about what's core to mindfulness and to make it a mindfulness-based intervention, and what can be adapted. And so we really kept the same core principles that other mindfulness-based programs have, and then changed the Weft, changed some threads to be able to really adapt it for this purpose. So we have themes and practices from MBSR, MBCT, but also integrating themes from mindful self-compassion, as well as the mindfulness-based interventions focused on addictions like mindfulness-based relapse prevention or mindfulness-oriented recovery enhancement, and integrated those targeting behavior change. So there's really, in our program, there's a focus on living well with illness, stress, pain, depression, and anxiety, and we take these three themes, longitudinal themes, throughout the program. In every session, there's some focus on connecting mindfulness with health behavior. There's interpersonal dyads, or interpersonal mindfulness practice, and then there's a thread throughout focused on compassion and kindness, really with an intention of having this program be trauma-informed. Because one of the other problems with mindfulness that predated this was not really taking into account the impact that trauma has. And when we're working in a primary care population, so many people have trauma. It's really important to start there with the assumption that everybody has had trauma, and when we come in with this compassion and kindness-oriented approach throughout, it really helps people to be able to stay within their window of tolerance and be kind to themselves and not overly punish themselves as they're trying to learn mindfulness practice. We also have specific skills practice around mindful values clarification. We weave in skillful action planning and intention setting, and as I said, we're just a trauma-sensitive, trauma-informed program. This is the 8-week curriculum. I'm not going to go through it in detail. I think I kind of just talked about it, but you can see how these three threads weave throughout. At the core is a model of understanding the importance of being with present moment experience. And one of the ways we talk about helping people come into contact and being able to be with and allow for present moment experience is through this idea of a diamond of experience. At the heart of the diamond is this sense of feeling tone or valence of the experience as pleasant, unpleasant, or neutral. But other aspects of the experience that one becomes mindful of are the thoughts that are emerging, the emotions that are growing, the physical sensations in the body, and the urge for certain behaviors, or actually the behavior if you've missed the urge and already started to act. So any situation and at every moment we have this kind of diamond of experience that we can become aware of. And what happens is in our present moment experience, we often are cascading among this diamond. And if we can ever stop and just really notice and allow any aspect of the diamond to just really be there, everything can start to slow down, and we can start to be able to really pay attention to what is. So the informal practice in this mindfulness-based intervention is what we call stop, ache, and go. And really it's this idea of the deep problem of experiential avoidance, that when we avoid what we're feeling, we often either disassociate or we get more of the experience. And how can we come into contact with what's really here for us in this present moment and then move through that? And the stop, ache, and go is really brings all the wisdom of mindfulness practice and depth mindfulness practice into a present moment experience. So we can, and there's because it's trauma informed, there are lots of off ramps within the practice to be able to use your own wisdom to decide what's right for you right now, to be able to be with your experience. So we encourage people to stop, or if you can't stop, just try to slow it down a little bit. And then to really turn towards your experience. And if you can't even turn towards your experience, just try to take some notice of breathing, or maybe take notice of the feeling of your feet on the ground. And begin to try to observe this diamond of experience with openness, really opening to what's here for you right now. Noticing the feeling tone, the pleasantness or unpleasantness or neutrality of the experience, and just allowing it to be as it is. So if there's an ache here, if as you come in contact with the experience, you really are noticing suffering, just accepting that that ache is here, and allowing it to be there, just for a moment. For many people, this may be hard, or your mind might start wandering away when this happens, and so you can anchor again to the breath. You can anchor with the soles of your feet and come back again. If there is an ache there, really bringing compassion to the experience, to yourself, to the areas of yourself that are suffering. Also bringing a sense of curiosity. There's a certain suffering in craving and in wanting, and sometimes bringing curiosity to the wanting can be helpful. And then just trying to hold that experience, holding it with some warmth. And there's different ways people hold it with warmth. This really comes from the Mindful Self-Compassion program. Sometimes just putting your hand on your heart or holding yourself for a moment just can help you be with that experience a little bit longer. And then from there, we're expanding awareness out from wherever the ache is to breathing, then to the body, to the senses, in a very similar way to the, in some ways, to the end of a 3-minute breathing space, if you know that from MBCT. And then, as you're kind of moving out, really taking a moment just to feel what gratitude feels like in the body, that you have something that you can do, and connect with those grounding values that we help people to elucidate within the values clarification exercise. And then from there, really opening to life, its beauty, its challenges, and orienting towards experience with kindness. So the 8 weeks of our program, actually in each week, is helping to kind of unlock one of these skills for people. And then people are building this experience to put this together. And when we do, it becomes very powerful for people to be able to come into contact with their experience in a healing way. So one of the questions that happens is you're saying mindfulness and behavior change. I thought mindfulness was about allowing things to be, not trying to change. And so one of the things that we really had to think about was how is mindfulness involved in change? And reconciling this kind of non-striving that you need to bring in mindfulness with the same thing, this need to actually change the way that we're behaving. And so one way of looking at it is that really everything is changing. Our behaviors would naturally change, except that we get locked in. We keep them the way they are, either by trying to fight them or by kind of giving into them and continuing with them. There's a lot of doing that we're doing and keeping behaviors going. So if we can step back, allow what is here, and we can actually let it change, it will. Change actually does start to emerge over time. And if we can hold our desire for change as more of an aspirational direction, it's kind of like an egg. If you hold an egg too tightly, if you hold that desire for change so tightly, what do you get? You've got a crushed egg and you got a wet hand, a sticky hand. If you hold it too lightly, what do you get? You get an egg that's cracked on the floor. So you have to figure out how to hold it just right. And so part of what we're learning in this is how to kind of hold this desire for change, this aspiration just right. And then how to do skillful goal setting, where we're not holding it so tightly that we actually create resistance within ourselves that keeps us from being able to go in that direction. Holding it just right and setting skillful goals that are reasonable and doing it with a sense of inner kindness, we're going to be more likely to be able to be successful. So just showing you, this is from the first pilot, that study 1 that I was talking about, of what our outcome was for behavior change. We did find that people in the mindfulness training for primary care group were more likely to initiate an action plan after 2 weeks of the program compared to those who were just in the low-dose comparator group. And we're going to replicate this, so I'll show you more about that when we get there. Anyway, this was our team for the Science of Behavior Change, focused on self-regulation and behavior, where we are building on this pilot data that I just shared with you. And really, the Science of Behavior Change model was looking at how does the intervention affect target mechanisms, and how would those mechanisms impact behavior change. So this is what this grant funding, this 5-year funding is getting us to look at. And I wanted to say that we are actually in year 5 now, and we're about to finish our third phase. So what I'm showing you for the rest of this time really is our data from our phase 2 of this study, and I'll have to come back in a year and give you like all of the data from everything. But I'll give you a sense of where we're going and what we found so far. So again, what we're looking at is trying to figure out what are the first phase of this grant was to do a meta-analysis and systematic review to find what are target mechanisms of self-regulation that mindfulness may be engaging, and then think about how do those mechanisms engage behavior change, and being able to see essentially is do these mediate the behavior change. And that's where we're going to be in a year once we get all our final data. But you can see here we have these three different large areas of emotion regulation, attention and cognitive control, and self-related processes. And within those, we have various different targets like emotional inhibition, emotion regulation, pain regulation, self-compassion, interoceptive regulation, self-efficacy, and attention and response inhibition. So for study 2, we had several aims. The medical regimen adherence aim, which was the primary aim, was does MTPC compared to this low-dose comparator for primary care patients increase rates of initiation of medical regimen adherence action plan or health behavior change? And then we also have these self-regulation mechanisms where we looked at the impacts of MTPC on inhibitory control, on self-compassion, on emotion regulation, and on interoceptive attention, interoception. And then we also have the behavioral health outcomes. And this was our core team for this project, for the phase 2 project. I'm very grateful. It really took just such a large team to do this. So I really just want to appreciate the work that everyone put in, and all the collaborative work. So the study 2 design was actually very similar to the phase 1 design. The difference was that instead of having people meet with their primary care provider at week 6 to 7, we had them actually watch an action planning video with the same online procedure at week 7. And that was because actually out of the 50 people that had successful action plans in phase 1, only one actually changed their action plan because of talking to their primary care provider. People knew what they needed to do for themselves. And so we were able to, as part of the program, we have a how to best take care of yourself worksheet. So they're able to go through and think about what goals they might want to set. And generally, we found that people were able to pick things that were what they needed. And it just served as another barrier for them to have to somehow vet their behavior change with their primary care provider. The other thing that we did in study 2 was call people in both groups, because we realized that just giving people the 60-minute introduction might not be the perfect standard of care control, because people might meet with their therapist, meet with a provider again. So we called people every 2 weeks in the low-dose comparator as well as in the other group, and just said, we want to make sure that you're practicing, or we wanted to see how your practice is going, and we wanted to see how the study is going for you. And so we called people every 2 weeks during the process to encourage practice in both groups, really to make sure that we had an attention match with study staff for the comparison. So in this, we had 467 people referred from primary care during this year that we did a phase 2 study, and we ended up with 136 people randomized, 92 to mindfulness training for primary care and 44 to the low-dose comparator. This is what the timeline looked like. People came into an orientation session. They had a informed consent. Then once they finished their baseline surveys, they got randomized. They went through 8 weeks. Everyone got this action planning video and survey at week 7. And then after week 8, at week 8 and week 9, we did this action plan initiation survey. And if people had, and we took whatever was the highest level of initiation in those first 2 weeks as our primary outcome. And this is the survey that we did. We basically asked people to choose what category of change they made to support their chronic illness self-management or their health behavior change, and they wrote down what their goal is, and then we asked them to rate did they meet their goal, and we a priori said that anyone who had a 5 through 7 reported would be considered someone who initiated health behavior change during that time. So around that week 7, we integrated in this SMART goal setting as a skillful way to to set a goal as a goal that's specific, measurable, agreed upon, realistic, and kind of kind to oneself, and time-based. So they had to do it within this 2-week period. And these are just some sample action plans. People made commitments to, bike or run 1 to 2 miles 2 or 3 times a week, to meditate before going to sleep, to restart diet control, to lower alcohol intake, to increase exercise. Everyone had their own action plan, and this was really this idea that if people are setting their own action plans in their own words, they're going to be more likely to be able to carry them out because it's going to align with their motivation. So this was the primary outcome for the phase 2 trial, and you can see on the right side here, the red is mindfulness training for primary care, and the blue is low-dose comparator. That in that kind of initiators range, you see a lot more red, and that's because 58% of people in the mindfulness training for primary care did initiate behavior change within 2 weeks, compared to only 32% in the low-dose comparator, which was significant with an odds ratio of 2.9. So after that, after replicating that, now in 2 studies, we are starting to look at these self-regulation mechanisms that may be helping people to be more likely to make behavior change after an 8-week course like this, or 8-week group like this. And specifically, we were looking at these three areas of our framework. So I wanted to start by talking about interoception. And interoception is a way of describing the sensations in our body that are related to homeostasis, that are related to, if you think about the temperature in this room, we're able to keep the temperature in a very small range, and we do that by getting information back about what the state is in the room, and then by making some change. And so interoception really is picking up all these different sensations in the body, things like thirst, pain, itch, hunger, breathlessness, temperature, sensual touch. And they use often very similar neural pathways in the brain and present to similar areas in the brain as well, and give us a sense of how our body feels in this moment and what it needs. All of these things, if you think about it, also when they're not in whatever that window is of comfort, do motivate us to make some kind of change. On that note, I'm going to take just a sip of water. So homeostasis is kind of keeping things at a set point. Allostasis is this idea of using prior knowledge to actually predict, based on what you're sensing, where you're going, and in advance starting to try to make a change. It's a little bit complex, so I'm going to try to explain this, and I'm happy to talk afterwards to anyone that really wants to dive into this. But one of the things that happens with allostasis is that as you're predicting what's going to happen, you then get information back, and you're not always right. And there's some sense of surprise there. And so because we're constantly simulating our reality based on the simulations of what we expect is going to happen for our body is starting to make changes. And this is based on several models. Lisa Feldman Barrett has an allostatic interoceptive regulation model for emotions, and I think this is a model that's becoming more prevalent. So the idea is when we simulate an experience based on our prior knowledge, it may or may not actually line up with current sensations. And when it doesn't, there's some surprise there. And that surprise we usually experience as either, often as an unpleasant experience that we then want to try to resolve. So there's different ways of regulating our interoceptive experience, and one way is called active inference. And that is where I feel thirsty, so I actually drink. Or I'm feeling panic, so I take a benzo. Or I'm feeling panic, so I reappraise the situation and tell myself that it's not something that's really serious. And what I'm trying to do is bring my internal experience to where I think it should be. right? It should be like this, and so I'm going to change my experience to get it where it needs to be. So there's another idea about the way that mindfulness might work, and that's that we might actually be doing what's called perceptual inference, which means instead of deciding to move our body's experience to where we think it should be, to where we predict it should be, instead we start to just accept that our prediction we move that towards what it is that we're perceiving right now. So by doing that, this is called perceptual inference. It's a way of kind of regulating ourselves to start to just expect what is here right now, instead of expecting that we're going to get what we're predicting. And so when you look at interception across psychiatric disorders, what you can see is that interception is this idea of being able to feel what the body's experiencing right now. And interoceptive regulation is kind of a broader idea that includes how we attend to our body, how we then appraise it. Do we judge it as pleasant or unpleasant, and the thoughts that come around what we're experiencing, and then how do we regulate it? Do we do it through rumination and suppression, where we just kind of stop listening to our body and then get lost in maybe catastrophizing or confusion or disassociate from our body, which so many people do? We actually had a talk last night too by Dominique Mellenbranc at our center, who was talking about especially when people have bodies that are not feeling welcomed, maybe because of race or culture within a certain as a community, they may actually start to disassociate from their body in some ways, or keep themselves from actually feeling what's going on in their body, and then cutting off the ability to be able to make behavior change and be able to get like real deep emotional healing and understanding. So there's all sorts of reasons why people might kind of get into one of these ways of regulating. So when it comes to mind-body connection, you could use active inference, or you could use perceptual inference, which is this acceptance or non-appraisal of the present moment experience. So just to show you what happens here, this is a really great paper by Numenma in PNAS back in 2014, where they just asked people, how are you feeling and where do you feel it in your body? And what they found is that all major emotions actually have a body signature. It's different for all of us, but they often can be similar. When we feel angry, we feel heat in our throat, and we might feel heat in our hands. When we feel happy, we might feel a sense of lightness or warmth in our head. One of the things that's most prominent, though, is when people feel depressed. If you look at that depression, that blue is a lack of sensation, that people actually stop feeling their body. That kind of rumination and suppression kicks in, and people are disconnected from their body sensations. And this interoceptive dysregulation, there are neurobiologic reasons for that. And as it happens, people actually are unable to then kind of notice how they're responding to internal cues. They become more internally preoccupied, and their attentional focus becomes more and more focused on thoughts in their mind and in their head, and become less and less connected with their body. It becomes harder and harder to motivate to do anything, because you need that interoceptive component to really unlock motivation for behavior change, and people get into real cycles of regulatory dysfunction. This is just a study that, a famous study by Avery in 2014 that looked at folks who were depressed, comparing them with healthy controls. And you can see here in the dorsal medial insula cortex. So the insula, if you peel back your frontal lobe from your temporal lobe, you'll find this little island, which is the insula, which actually we didn't learn about in medical school. But it turns out is involved in all major emotions. And it's where it's the interoceptive cortex. It's where we experience these feelings of the state of our body right now. And you can see here that among healthy controls, they had much more activation in their insula during an interoceptive task where they're asked to pay attention to their body sensations. And that relationship is that as people got more depressed, there was less and less activation in this dorsomedial insular cortex. There was, as they got more depressed, there was more and more connectivity with the amygdala and medial orbitofrontal cortex. So it almost seemed like there was some signal that was coming from these areas that was essentially shutting down people's experience of the state of their body, cutting them off from their body. So this is a secondary analysis that we did of our baseline data in our phase 2 study, where we looked at the MAIA, which is the multidimensional assessment of interoceptive awareness scale that has 8 subscales, and looking at depression. And what we found that different aspects of interoceptive awareness, like the ability to trust what your body is telling you, the ability to listen to your body sensations, interoceptive body sensations, the ability to use body sensations in self-regulation, to use body sensations in emotional awareness, and to notice your tendency to notice what's happening in your body. That these are substantially disrupted in moderate to severe depression. Both actually in mild depression, people stop trusting their body. It seems to be associated with people not trusting their body, and then as it gets more severe, they continue to not trust, and then you see people stop listening to their body. They stop noticing what's happening in their body. They start to not be able to use body sensations to help them inform emotional awareness, and then ultimately they are not able to use body sensations to help with self-regulation. So in our pre-post data, in the between, oh my goodness, I'm gonna have to use body sensations to cope with ending early here. So I'll try to get through this quickly. So what we found was that people had substantially greater interoceptive awareness after 8 weeks of mindfulness training, and that part of what mindfulness is helping people do is help them listen to what their body is trying to tell them. We also found that we looked at interoceptive accuracy, which is people's ability to be accurate about what's happening in their body. And what we found was, I'm just going to point out here, that people who were more likely to listen to people who were more accurate at being able to count their heartbeats at 8 weeks were also much more likely to listen to their body at 24 weeks, so by the end of the study. So that as we start to listen to our body, we become more accurate, we trust our body sensations, we're more likely to listen to our body, and that's going to help us likely make behavior change. This is just showing that in these interoceptive fMRI tasks, we did find increased activation in the right anterior insula, and that it was associated with these changes in emotional awareness and self-regulation. We also found reductions in difficulties in emotion regulation that were significantly, in between group analysis, significantly different, with an effect size of 0.58. I think because of time, I'm not going to get into this, but we did do neuroimaging of pain regulation with cuff pain, and found that when people have reductions, that people have increased activation in this dorsal posterior insula, that seems to be related to decreases in the amount of pain people experience. The last piece that we looked at really was trying to understand the impact of the default mode network. So this is another form of self-related processing. When we sit down to meditate and we're asked to pay attention to our breath, our mind often goes to one of several places. It goes to the past, memories about the past. It goes to thinking about the future. We might think about others or others' thoughts. We might think about whether or not we're doing what we should do, if we're doing it right. These areas that are involved in autobiographical memory, envisioning the future, theory of mind, and moral decision-making are all areas that are major nodes of what we call the default mode network. And this is what happens when we stop doing anything. Our mind goes into this network, and this uses up about 80% of the body's energy every day. Of the brain's energy is spent in this default mode network, and it's kind of what we're doing when we're mind wandering. We reliably activate and deactivate these nodes together, and in some ways, this is the nodes, the PCC and this medial prefrontal cortex are these nodes in the default mode that create this narrative self. If the insula is the story of I am, it's where we experience this sense of I am in this moment, and this is how I am in this moment, the default mode network is where we experience this sense of the narrative self, the story of myself, weaving myself into the story of past and imagined future. And this study showed that when we ask people if their mind is wandering, when their mind is wandering, they're less likely to be happy than when they're present moment focused. So the default mode does potentially is associated with some of the suffering that occurs. And it's partly because of this, right? It's because of these questions like, am I doing this right? Is everyone looking at me? I'm not going to say that one. But even when we're practicing, the default mode becomes active, and self-critical rumination arises, which is one of the most common ways that people get stuck in default mode. And one of the antidotes to self-critical rumination is to bring self-compassion and compassion to ourselves. And what we were able to find in our study was that mindfulness training for primary care actually increased self-compassion as well. We did neuroimaging looking at, and we are continuing to do neuroimaging, looking at what does self-criticism look like in the brain? Because self-criticism really has this toxicity to it. And if we can figure out what that signature is, then we might be able to understand both how mindfulness works and be able to target something that's causes a lot of us pain. So what we did was we had people alternate between scenarios where they would think about a self-critical moment versus a neutral moment, and then they would allow themselves to kind of dwell in that self-criticism or try to reassure themselves. And what we found was actually that self-criticism was reduced after mindfulness training for primary care training at 8 weeks significantly, and that these are the brain's activations related to self-criticism. You can see that there's this dorsal medial prefrontal cortex, which is the front node of the default mode network, was really activated. And then after mindfulness training, we see strong reductions in this area, as well as in the orbital frontal cortex, which is an area involved in affective regulation, that was reduced after 8 weeks of self-compassion training. Of mindfulness and self-compassion training in MTPC. I did want to mention this because the funding for this project came from OSHA for a pilot study we looked at. We also looked at what does just 2 weeks of self-compassion look like, and what are the changes in the brain that occur. And what we found here was that at 2 weeks, we're not seeing those kind of deep affective changes that you see after 8 weeks of a mindfulness training program, but we're seeing instead changes in the dorsolateral prefrontal cortex. So we know this, that early on in mindfulness, and I think now early on in self-compassion, people use a lot of reappraisal strategies. So you think, oh, I should be kind to myself, or oh, let me be kind to myself now. It's an active response. And then what happens, what we hypothesize happens is then by 8 weeks, it starts to become, as you've been practicing more and more, it starts to become more of an automated response where people are able to allow themselves to experience the moment and are more naturally and automatically less self-critical. So these are the ongoing studies we have that are building on these data that I just showed you. The first is the UH3 NCCIH-funded study on science of behavior change. We have 114 people. I think we're at 90 right now, so we should be done by this summer. And we're going to have 40 subjects in neuroimaging, pre and post. We have accelerometry activity tracking, looking at activity change, daily eating activity, and sleep diaries. We also have brought in an inhibitory control task. I'm not showing our pilot data on, and discounting, hypothetical discounting task, looking at impulse control and inhibitory control. We're doing heartbeat detection in the entire study, and we'll be able to do these mediation analyses, looking at Maya, which is the interoception, and looking at emotion regulation and looking at those subscales. We've also been able to build on this work. We've been funded in an R33 project for a 5-site RCT bringing this mindfulness training for primary care program for primary care buprenorphine treatment for patients with opiate use disorder. And we're using similar self-regulation mechanisms to see if this can be impactful in that population. And we've continued to adapt and develop our intervention to be trauma-informed and accessible to primary care opiate use disorder treatment. I only have like 1 minute left. I just really want to say thank you to all of our mindfulness training for primary care group leaders. This really took a team, people co-led together across our region, and I'm just really grateful to everybody here. And it's been wonderful to see everybody's process as they, took their primary care background or their mental health background and really brought into that this development of capacity to train people in mindfulness and to really bring self-compassion to themselves and to others. And this is the research team, and there's even more people, but these people have had really big impacts, as well as translating our mindfulness training for primary care program into Spanish and into Portuguese. And we are running our trials in Portuguese right now, and we're going to start our Spanish trial in the fall. This is our website. We do also have an advanced fellowship in mindfulness that started last year. This year we have a psychologist postdoc as well as a fourth-year psychiatry resident. We welcome people to apply for this, and you can read about it more on our website. And our Mindful Mental Health Service has really expanded, really with the focus on accessibility, so that no matter how, as you could see in our consort diagrams, we had to exclude some people from primary care programs. Sometimes it was because of the timing. Sometimes it was because they had too many psychiatric comorbidities. One of the things we found was we had an exclusion in our for bipolar disorder in our NIH protocol. And unfortunately, I think one of the things that we noticed as we were doing this, that a lot of people of color were getting diagnoses that were more severe than we thought they necessarily should be early on, and they would end up being excluded. And so one of the goals really of Mindful Mental Health Service was to ensure that we had really good inclusion and accessibility. So no matter how severe your mental health is, whether you have psychosis or bipolar or addiction or severe trauma, we do have a way for you to be able to come into our system and be able to get a mindfulness group. And no matter what your experience is, this is something that mindfulness can help you to reduce suffering in this experience of being human. And if you're human, then we have a mindfulness program for you. So that's, I'm going to stop now and leave time for questions.
Hi, I'm Sharon Dickinson. I'm the Reiki coordinator here at Brigham and Women's Hospital, and I am deeply grateful for this opportunity to hear this presentation. And I deeply want to learn more. When we're with a patient, we have about 20 minutes, and I want to learn more so that I can help our volunteers because Reiki, I think, is parallel to mindfulness. It's under the same tent. And so where can I learn more? Do you have books, articles, websites? Bring it on. Sock it to me.
Well, I think going to our website is a way to learn more. We have various different trainings that people can engage with. We have our MBSR trainings, our mindfulness-based stress reduction, mindful self-compassion trainings that run every season. We have groups that are running. We have the mindfulness-based cognitive therapy trainings as well. We're going to have we generally have our group leader trainings in the fall. So if you watch our website, you'll see when those are. I think they're usually in September or in October, November. We do have this advanced fellowship in mindfulness. We collaborate with the Institute for Meditation and Psychotherapy, which has a certificate course for mindfulness and psychotherapy, which forms the didactic element for our fellowship. So you get that. In our fellowship, you get that for free. You also get the MBCT training and mindfulness training for primary care program as part of the fellowship. I think if you go to our website, you can see links to papers and books from our faculty, which is a good place to go. If you Google mindfulness, I'd like to say that you could find it. You might get overwhelmed. David Black has the American Mindfulness Research Association. You can get on that list, and they'll send you an abstract, basically titles and brief descriptions of the 50 papers that come out every month on mindfulness, and you can use that to decide which ones you want to review and find if you have access through a library. Yeah.
Zev, thank you so much for that talk and a lot of the great research that you did to demonstrate and document a lot of these mechanistic pathways. So I was really struck by as a primary care physician myself, when you're going through the study design for the second study, I was actually really sad to hear that that piece of it was taken away. And part of it is like, okay, so the primary care physician is not really having a big impact on these behavior action plans, but I still feel like their involvement and their integration must be crucial, on a longitudinal.
So the data we have from acceptability around the program was, I am so happy that my primary care provider referred me to this program. And I am so happy I can talk about this interest and that my primary care provider recognizes the importance of this for me. So I think I wasn't saying the primary care provider was not important. Please don't take that because it's actually the exact opposite. I was just saying that forcing people to go have that conversation during that week, it's very hard sometimes to get an appointment with your primary care provider within a certain week. And so that was causing like a logistical barrier for people.
Right.
I think many people who had chronic illness were speaking with a primary care provider. They knew what they needed to do from those conversations. They just hadn't been able to do it before. And now the primary care provider said, look, I think this program is going to help you to really be able to activate and help you, with your stress, with your pain, with your illness, so you're going to be able to make the changes you want. And then they found they were able to, and they were very grateful that the primary care provider thought of that for them and was thinking about them in this holistic way.
Yeah, so I guess it kind of answers my question, because I was really interested in knowing then how that sort of integration within primary care was happening, because really we spend 80-90% of our time in clinic, trying to get folks to make these behavior changes for, diabetes and hypertension and whatnot. So, sort of seeing
so it's completely integrated, and because it's a patient-centered medical home, we're also bringing mental health into primary care. So what we found is the communication as well. Patients really appreciated that things that may have arisen in the group would somehow get back to the primary care provider, and then there'd be this communication. And we got this really nice letter to our CEO from one of the patients who had depression and chronic pain, who just really spoke about what it was like to have this team. He had his therapist, he had his mindfulness group, he had his primary care provider working together to really help him to be able to understand himself, and had reductions in pain, and just spoke about how that 100 hours was such time well spent, and that was really useful. That was really beneficial for our center, for the hospital to realize the integration that we were creating, and the way that really helped to bring forth the vision of a patient-centered medical home, and to really help patients feel like they are at the center and they're being seen, and that they're able to see themselves.
Thank you.
Thank you.
Hi. So you said that the program is reimbursable by insurance. So I was just wondering, is there like criteria that people have to meet? Like, can anyone take part, or do you have to be kind of depressed or have something?
Right. So for this study, everybody had a diagnosis of anxiety, depression, or stress disorder. And about 55% of people had some comorbid chronic medical illness. So so when we were building group psychotherapy, we used the anxiety, depression, or stress codes. If we did do a group medical visit, then we would bill that as a primary care visit, and there are certain other types of data the primary care provider wanted to do to review medications, to review vitals, and to make sure that they had that kind of holistic medical approach as well, in addition to the curriculum. So we have within our manual basically how do you set up a group using this curriculum with if you're a primary care provider, how do you do it? If you are a mental health provider, how do you do it if you are working together and co-leading together?
Quick question. Thank you so much. I was wondering if you could actually speak a little bit more to the relationship between the insula, or it sounds like the various insulas, to the default mode network.
Yeah. So what we know, so there used to be this idea of kind of task positive and task negative networks, so that when you're not doing a task, the default mode would activate. And so if you were really paying attention to what's happening in your body, getting into what we would call like your experiential self, then that would, then when you do that, that often downregulates the default mode areas. Similarly, if you get into an executive function area or central executive network, it will downregulate your default mode. There's been a lot of work that's been done on large-scale brain networks, also including a salience network. So whether or not that task positive, task negative model still holds, I think is something of active debate. But I think what we know is that when we come into our body and we start paying attention to what's happening right here and now, we do see the reductions in the default mode. That's one of the things that happens when you sit and practice meditation and you start meditating, is that you start to pay attention to what's happening in your body, and then usually 6 to 10 seconds later, the default mode starts to work its way back again, and you start mind wandering. Then you have to notice that, orient your attention back, and come back again. Yeah. Is that it? Well, thank you very much for the time, and for I will be around afterwards for 15 minutes if people want to come up and talk or about anything else. Thank you very much. Bye.